Our final subject for this issue of ACCEL features a talk Christopher Kramer had with Dr. Robert Ross, professor of exercise physiology at the Queen's University School of Kinesiology and Health Studies in Kingston, Canada. They cover implementing CRF measurements in clinical practice.
Robert, welcome.
Happy to be here.
So, why is cardiorespiratory fitness important?
I think the evidence is pretty clear now that cardiorespiratory fitness is an attribute that explains morbidity and mortality beyond common metabolic risk factors. In fact, it explains morbidity and mortality beyond smoking and diabetes and family history, etc. So I think it helps clinicians manage their patients. We also know now, very recently, in the last 4 or 5 years, we have very good evidence suggesting that the addition of cardiorespiratory fitness to normal variables within risk engines actually adds to the value of that predictor for morbidity and mortality. So, for example, if we add cardiorespiratory fitness to the Framingham, which is known to many of our cardiology colleagues, it actually enhances risk. And this is very important. So the bottom line is it helps clinicians manage their patients, and we think that's very important.
I understand there's an intrinsic and an extrinsic component to cardiorespiratory fitness. Can you tell us more about that?
There's a familial or genetic component, as there are to almost any attribute that we have, and fitness isn't any different. So there's, depending on the literature that you read, somewhere around 40% of cardiorespiratory fitness is probably controlled from what mom and dad gave you. But that leaves about 60% that could be affected by environmental factors. So, of course, in this particular case, we're talking about physical activity. So there is an intrinsic component, but the extrinsic component is much bigger and responds very nicely to physical activity.
So all of us could be highly competitive athletes, you're saying?
I'm not so sure that we all want to be competitive athletes. Of course, as you well know, the improvements that we look for in cardiorespiratory fitness that reduce risk are really extremely reasonable. And there's very solid evidence now that independent of gender, independent of race, independent of age, if you adhere to the physical activity guidelines, which are essentially 150 minutes of moderate to vigorous physical activity most weeks of your life, you will improve your cardiorespiratory fitness and you will reduce risk of morbidity and mortality substantially.
Excellent. So as clinicians, how should we go about measuring CRF in our clinical practice?
There's 3 ways you could do it. The first way is a non-starter, of course, and it's the way we do it in more research environments where we'll actually measure the oxygen that's consumed by the individual during the performance of a graded treadmill test or a bicycle test. This takes time, it takes expertise, it takes specialized equipment. That's unlikely to happen in my lifetime in clinical settings. The second way to do it is to do a submaximal test, and you don't have to have any special equipment. You might do a step test or a bicycle ergometer test, and using the heart rate that you obtain at a couple of different levels, you can predict your cardiorespiratory fitness or your maximal ability to consume oxygen. This, too, many would argue, is not practical for many clinical settings. So the third way that we've come to do it now is by using a so-called non-exercise estimation of cardiorespiratory fitness. So by that, we usually have 4 variables within an algorithm that are easily obtained in a clinical setting. They're usually gender, age, weight, and your physical activity level. And that physical activity level can be obtained by a simple questionnaire that takes literally seconds to do. And using those 4 variables, we can estimate cardiorespiratory fitness using the algorithm or a nomogram, whichever the clinician decides to use. There's 2 good pieces of information, I think, with the non-estimated fitness level. One is that they come very, very close to the directly measured value. But even more important than that, the literature now shows very clearly that the estimated fitness levels predict morbidity and mortality as well as the directly measured values. So this, I think, is very good news and really now provides us opportunities to allow clinicians, cardiologists in particular, the opportunity to counsel their patients in a very straightforward manner without sophisticated equipment, without requiring a whole lot of time. And I just think that's good news on so many levels.
Where can we find these algorithms? Are they online? Is it straightforward to download them and apply them in our practice?
It is. As a matter of fact, you can go to various websites to do it. I suppose someone could send me an email and I can send them the appropriate references. We are crafting an AHA statement on the utility of cardiorespiratory fitness as a measure in clinical practice. That should be ready fairly soon. But yes, those algorithms, if one searched for non-exercise estimations of fitness in the literature, they'd secure them, I think, very simply. But if someone drops me a line, I'm happy to send them to them.
Well, can you give us 2 take-home points for the ACCEL audience today?
I think the first point is that we now, and nobody doubts this, that lifestyle factors are a major contributor to cardiovascular disease. I don't think there's anyone on planet Earth that wouldn't appreciate that. What we need to do is we need to get more of our clinical colleagues measuring cardiorespiratory fitness in clinical practice. We need to have them counseling their patients with respect to physical activity. Even those with heart failure can increase physical activity, improve fitness, and decrease risk. I think this is very encouraging news. So measure these attributes, counsel your patients appropriately, and we'll do well.
I think that's a terrific message for the audience today. Thank you for bringing it to ACCEL.
Well, thank you for having me.
And that concludes this edition of ACCEL for June 2016. For details about studies discussed on ACCEL, refer to the written summary included as a PDF file on this disc. This issue of ACCEL qualifies for up to 4 Category 1 CME credits. To obtain CME credit, go to www.audiodigest.org/online testing. This is Alfred Beauvais for the American College of Cardiology. Thanks for listening.